Welcome to today's webinar on the role of evidence for the chiropractic profession. My name is Dana Mikan, Communications Manager for the College of Chiropractors of Alberta, and I'll be doing today's announcements for the webinar. On behalf of the College of Chiropractors of Alberta and Registrar Dr. Todd Halowski, we're pleased to host this webinar with guest speaker, Dr. Stephen Passmore, Associate Professor, University of Manitoba, who is both a clinician and a researcher. As we begin today's presentation, we would like to acknowledge that the CCOA office is within Treaty 6 territory, and we recognize our members who live and practice on Treaty 4, 6, 7, 8, and 10 territories. The CCOA is dedicated to improving Indigenous health and to supporting culturally safe and appropriate care to Indigenous patients and families across Alberta. Today, Dr. Passmore will present on the role of evidence for the chiropractic profession, answering 6 key questions. How can we communicate the truth? What is quality research evidence? What can we say with confidence? What can we not say with confidence? How do we address adverse events? What does the future look like? The presentation will be moderated by Registrar Dr. Halowski. If you have any questions during today's webinar, please add your questions in the Q&A section on Zoom. Our speakers will do their best to answer as many questions as possible. Please note this webinar is being recorded. Now it is time to introduce our guest presenter. Dr. Passmore is an associate professor at the University of Manitoba in the Faculty of Kinesiology and Recreation Management. He currently practices as a licensed chiropractor at the Wellness Institute at Seven Oaks General Hospital in Winnipeg, Manitoba. He maintains an active grant-funded research program and supervises undergraduate, master's, and PhD trainees. He has published more than 50 peer-reviewed journal articles. Dr. Passmore has been an active participant in numerous organizations, as shown here. In 2020, he was named Researcher of the Year by the Canadian Chiropractic Association. Please welcome Dr. Passmore.
Well, hello, everyone, and thank you very much for the kind introduction today. I'd also like to thank Dr. Todd Halowski and the College of Chiropractors of Alberta for the invitation to speak today. And I'll be talking about the role of evidence for the chiropractic profession. Well, when we were kids, your parents, probably taught you that honesty was the best policy. And if you're a parent, you're probably trying to instill right now in your children, always tell the truth. And historically, we've been taught that we should tell the truth or there will be consequences. And it was a concept that was so popular that it became a radio and then a TV show. And that TV show was so popular that in 1950, a town in New Mexico actually took on the name of the show when the host said that they would do a live broadcast from the first town to officially change their name to the name of the show. So the importance of telling the truth still rings true today. But how do we know how to tell the truth about what we're doing professionally? Patients ask us questions every day. And we need the highest quality, truthful answers that we can give. And we owe that to our patients as well as to our colleagues. So how do we do that? How do we search for the truth? Well, like many other things in our lives these days, we can always ask the internet and see where that takes us. Where does that lead us on our search for the truth? So I typed it into this website, and this is the definition that came up. The truth, the real facts about something, things that are true. And that made me think about, how do we know what is true? We hear about evidence. How does that relate? So I searched for that as well. And evidence is something which shows that something else exists or is true. So having evidence to support something. But evidence can also be material that's presented in a court of law in order to help find the truth about something. So, we've heard about evidence-based, and how do we know what's evidence-based and what isn't? Well, I decided to do one other search, and I looked for research. And research is a careful study that's done to find and report new knowledge about something. And so really, research is a search for the truth, trying to find evidence and look for the truth. So the name of the game was Truth or Consequences, but what does that actually look like in our world? Well, we as chiropractors are a regulated healthcare profession. And what are the consequences of not creating trust in that environment? Well, we would have public distrust where the public wouldn't trust us. We could have professional mistrust where members of other healthcare professions or other professions may not trust us. Or we may even run the risk of being left behind. And so as the healthcare world continues to evolve, if we don't stay on top of being able to tell the truth in an effective way, we would run the risk of being left behind. So let's stick with the truth. But how do we know how to tell the truth? How do we know what to do? How do we know what not to do? And how do we know when to do it? Is there some sort of an instruction manual? Well, sure, in the case of a simple machine, there are instruction manuals, simple little devices that we all have in our everyday worlds. And that instruction manual can be generated at one source on the day when that device is created. It answers all the questions. Isn't that nice? How convenient. But when we look at this picture, we don't see a simple machine. We see the human body and the human body in all its complexities. And we know some of the things that we can do to make that human body feel better. We know some of the things that we could do would actually make it feel worse, which would be, an adverse event. And we know a little bit about when to do those things in terms of frequency of care or different conditions or pathologies or aging tissues that people have. But is there some sort of an instruction manual? Well, we've got anatomy textbooks, but that really just shows us the inner structures themselves, not necessarily how they all work together. So we don't really have something. It's a very complex mechanism, and there's no rigid or unchanging instruction manual. All we know is that we don't have all of the answers. Well, isn't that kind of frustrating and how complicated? So what we have to be is open-minded, and we have to be willing to learn continuously. We have to be willing to be flexible, and in doing so, we can be honest. We can say, here's what we know right now, and here's what we don't. And this is always changing as what we understand continues to evolve. And so, the universe was once thought to revolve around the Earth. And then a new theory came along, and we realized that it didn't. All of the animals in the known world never seemed to change, and until we understood that they did. And so what we know is always fluid. And the sooner in life that we accept that, the more enlightened we can be in our understanding in how to describe things to our patients. So maybe the right question to ask is, how do we know what sources of information to trust? And how do we know when to change our thoughts and viewpoints? And how do we recognize when to evolve? Well, if you're on this conference call, the odds are you graduated from chiropractic college. So congratulations on that. But does that mean that we never have to learn again after that day of graduation and passing your board exams? That should be where our professional life starts. And we don't want to just build our clinical practice on what was absolutely true the day we got our degree, because knowledge tends to change over time. Then we have to sort of reflect on our practice environment. Do you practice on your own in isolation? Or do you have a network of people that you can talk to, even if you are in solo practice, who you can share your opinions about, your thoughts, you can read about research and go through the continuing education events with? Do you have a professional network, either in your clinic or beyond, that you can share your ideas with? Or are you running the risk of being an island where you're cut off from the rest of civilization? Well, according to Johns Hopkins University's Faculty of Medicine, we should always be reflecting and learning and working with others. And that can be by having a network of colleagues that we trust, or it can be by working in a multidisciplinary environment where we're exposed to different things and different educational opportunities. And basically where we start is with inquiry. So we have a question of some sort, and that takes us to this practice question. Then we look to see what evidence is there for that practice question to help us try to answer what's known at that time. Then we look to translation. So how do we communicate that evidence to our patients, to our colleagues, and how can we use that to shape best practices? Then if we're engaged in best practices, that can lead to improving our practice, and we can reflect on the state of our practice at any moment in time, which may lead us to new questions of inquiry. And all this time, this learning and practice cycle should always be happening, where we're learning new information, we're reflecting on what we're learning, and then we're applying that to practice, we're reflecting on our practice, and then having new learning emerge, which can then go back to asking new questions. So I really like this model for trying to look to see how we can understand what we're doing in a clinical practice environment. And what I like to do is I like to think of evidence as being like little bricks. And so we have these little bricks that can be the foundation of our understanding and our knowledge base. And we can have those bricks and hold them in our hands and show them to other people. And we can say to our patients, look, here's this brick of evidence or knowledge. And we can share that with other healthcare professionals as well, because those professionals also have their own evidence base that they draw from. And they look at those bricks and they say, okay, we understand these are our bricks and those are your bricks. And maybe together we can build something strong. And so they understand the importance of them. But, where do these bricks of knowledge come from? Well, each of these CCRF-funded professors have spent their entire careers building bricks for you at major research-intensive and medical doctoral universities across Canada. So myself included, I build bricks. Each research study that I conduct is like a little brick, and each one that gets published has basically been scrutinized for quality control by the peer reviewers of that journal. So there's me, and there is the University of Manitoba. And, as a brick builder in my career, I've built over 50 bricks, and maybe that's enough to build this little shed that we have in the corner of the screen. And that's okay. But in this instance, for our profession, 50 is not enough. Every person that walks through your clinic door is seeking the help and trusting the foundation that you've built is strong and based on a lot of knowledge. And my efforts alone are not enough. So now we can look at the pooled efforts of the CCRF researchers. So we have this nice team of researchers across Canada at all of these major universities that you can see the logos on the screen of. And together, we've actually generated more than 1,444 peer-reviewed research publications. So that's a lot of bricks. And as you can see, when you have a lot of bricks, you can build much larger and cooler structures than just my little shed that I built by myself. So looking at that big picture of everyone's work pooled together, we can really create some pretty amazing things. Now, just based on a show of hands, how many of you have read all 1,444 of those research articles? Okay, I'm looking out there. I don't see any hands going up. I'm not going to lie. I'm not going to put my hand up either. 1,444 is a lot of articles, and no one person can really master all of that information and have read and really processed all of that information. So if you did read those articles, great. And assessing those articles for quality and usefulness is something that takes a really long time to be able to do. And not all bricks are created equal. Some bricks are made out of snow. And if it's really cold outside, well, that's okay. You can have a usefulness with these snow bricks, but they do melt in the warm weather. And then what about a virtual brick? Well, that's good in Minecraft, but what about in the real world? Well, there's a hierarchy of evidence, and we can use it to explain the integrity of each of these different types of bricks. So we have primary studies, and primary studies are like the brick that I showed you and was talking about a little bit earlier, where maybe it's a randomized control trial or an observational study like a cohort study that involves actual patient outcomes. So these are pretty solid bricks, and the conclusions of those are quite interesting and meaningful for our profession. Sometimes we have case reports or narrative reviews or animal or laboratory studies, and these are more like the snow bricks. They can be useful, but they're not quite as solid or robust as the primary studies tend to be. And then we have these ones right at the top of this pyramid, and these are our secondary pre-appraised or filtered studies. And these are very exciting. So these are systematic reviews, meta-analyses, or clinical practice guidelines. And these are basically a summary of the highest quality bricks. So an inspector has come along, looked at all these really high quality bricks that have been generated from the randomized control trials and other cohort studies, and then used those to put them all into a wall together to tell a bigger picture or a bigger story and try to create a more solid basis of evidence. And those people that are publishing those clinical practice guidelines really are like that building inspector that's looking at that wall, trying to look at the structural integrity of it and think about safety and the larger picture. So we in Canada can turn to the CCGI, or the Canadian Chiropractic Guideline Initiative, as our building inspectors. They're curating the highest level of understanding that we have at a particular moment in time. And through the CCGI, we have a team that's inspecting all these bricks as they're being made, and they're building all these different walls. And these walls are intended to stand up to not just our own inspection and getting them out there and having them peer reviewed and published in journals, but these are things that meet professional standards. These are tools and supports that meet government standards, and they're created with public safety and best interest in mind. So you're in private practice, and a physician comes up to you or emails you and asks you, who can I refer to you? And where's the evidence for why I can refer that patient to you? Well, based on the evidence that we know today, what can you say? Well, you can go straight to the building inspector, go to the clinical practice guidelines. And if we do that, we actually find some pretty interesting information. And so we can say, okay, where are we with acute and chronic low back pain? Well, we're in a pretty good spot. Based on a CCGI guideline, we know that a multimodal approach, including spinal manipulation and other commonly used interventions by chiropractors, including self-management advice and exercise, is an effective treatment strategy for both acute chronic pain and acute and chronic back pain with and without leg pain. And that guideline isn't just supported by our profession, but also the American College of Physicians. So a few years ago, they put out a guideline that agrees with that says for chronic pain, clinicians and patients should initially select non-pharmacological treatment with exercise, multidisciplinary rehabilitation, things like acupuncture and spinal manipulation are all supported. And then the World Health Organization also put out a guideline based on low back pain. And they developed some evidence-based recommendations from these high-quality clinical practice guidelines. And they inform people that when you have low back pain with and without radiculopathy, that there's a benefit to education, exercise, manual therapy, and cognitive behavioral interventions. So that's a lot of really good support for the case of why we should see people with back pain. And these are just the references for those. And my understanding is that you'll get these sent out to you. So if you want to have those at your disposal, that's how. So for back pain, we're looking really good. What about cervicogenic and tension type headaches? Well, we're looking pretty good there as well. And so neck pain and headaches are very common comorbidities in the population, and tension type cervicogenic headaches can be treated effectively with specific exercises and manual therapy that includes spinal manipulation. So these can be considered as adjunct therapies to exercise in treating patients with cervicogenic headaches. And the management of tension type and cervicogenic headaches can be patient-centered. So there's our article on that. And what about acute or chronic neck pain or whiplash? We're looking good there as well. We've got some clinical practice guideline support there. So a CCGI guideline found that a multimodal approach, including manual therapy, self-management advice, and exercise is effective in treating both recent onset and persistent neck pain. And there's the reference for that one. So we're looking good on those fronts. What about extremities? Well, specifically for management of the shoulder, we have a clinical practice guideline. So shoulder pain of any duration can be effectively treated with laser therapy, multimodal care, including heat or cold, joint mobilization, and range of motion exercises. And you can also use cervicothoracic manipulation and mobilization to help improve that shoulder range of motion and decrease the pain. And there's the reference for that. So lots of good guidelines on those fronts. What about stenosis? It's a specific degenerative condition. It's a little more chronic in its presentation. Is there anything that we can do for that? Is there enough evidence to support our intervention? And the answer is yes. So the CCGI had a clinical practice guideline that came out looking at lumbar spinal stenosis that caused neurogenic claudication, so those symptoms into the lower extremities, and found that patients can initially select multimodal care and non-pharmacological care options, and that we can provide education, advice, lifestyle changes, behavioral change techniques, home exercises, manual therapy, and rehabilitation to try to improve their clinical presentation. And a recent systematic review further backed up that clinical practice guideline, suggesting that there's a moderate quality of evidence looking at a multimodal approach, including manual therapy and exercise with and without education, to effectively manage patients with lumbar spinal stenosis. So recently, we were faced with an interesting challenge. The world shut down, there was a pandemic, and suddenly we, in some provinces, were no longer allowed to be in our physical clinical practice seeing patients. So that raised an interesting question. Is there any value in using telehealth for non-acute musculoskeletal conditions? And we found that yes, there is. So a data synthesis was conducted looking at synchronous telehealth that involved video conference or telephone calls alone or in combination with in-person care. And they found that it led to similar outcomes to in-person care alone for non-specific low back pain, general osteoarthritis, hip and knee osteoarthritis, and non-acute headaches in adults. So there's a lot that we can do in that remote environment as well. And there's the reference for telehealth. Now, also coming off of the tail of the pandemic, what about infection? And that becomes an interesting question to consider as well. How do we help that? Do we impact that? Do we know? And the conclusion that came out of the recent evidence for that is that there's no clinical evidence that supports or refutes claims that spinal manipulation therapy is efficacious or effective in changing immune system outcomes. There are a few basic science studies that suggest that there are changes in some immunological and endocrine biomarkers, but the clinical relevance of these findings isn't known yet. So given the lack of evidence that spinal manipulation therapy is associated with prevention of infectious diseases or improvements of immune function, we need further studies before we can make any claims about effectiveness in that capacity. And that's the review that provided that indication. What about non-musculoskeletal disorders? So there are things like infantile colic, childhood asthma, high blood pressure or hypertension, primary dysmenorrhea. Where is the evidence for those right now? Well, a recent review found that there was no evidence of an effect of spinal manipulative therapy for the management of non-musculoskeletal disorders, including infantile colic, childhood asthma, hypertension, and primary dysmenorrhea. So the finding challenges what some folks believe is possible with spinal manipulation. And this is the systematic review that came to those conclusions and made that statement. So you may be asking yourself, where do you go for this information? How do you find this stuff? Is it all just coming and signing up to a seminar like this where I can share this information with you? Or are there places that you can go in your own time to really explore these concepts of where is the evidence and where is there not evidence to help describe to others what we're doing? Well, the Canadian Chiropractic Guideline Initiative has a really solid website and a lot of resources that are available to you at no fee or charge. And so you just have to go to their website and you can look up any of these different musculoskeletal conditions, and you can click on it, and it will tell you if there's a guideline there. It will tell you if there's a systematic review, and it will give you some advice about what you can do in your practice for these specific conditions. Also, it provides specific exercise videos and forms, outcome measures, so that you can document a person's course of care and make evidence-informed decisions about how they're responding to care. You can listen to some podcasts just for your own general knowledge, and you can learn more about virtual care as well if that's something that interests you, because there's a lot of rural and remote communities that don't have a chiropractor in their community. So if you could be a participant through telehealth to be able to help those communities, then there's benefit to that. That's according to the systematic review evidence that we've seen. But what about adverse events? And it's important to be upfront about these things, that not all things are sunshine, and it's important to have a conversation upfront and to be transparent about adverse events. And any clinician from other disciplines will tell you that there are adverse events associated with the things that they do. So anything from simple medications to more complicated surgical procedures, there are always adverse events associated with it. So we shouldn't take offense that people can have an adverse event related to the kind of care that we deliver. It's just a part of administering care in general. So being aware of what happens and how to avoid it is really one of the best things that we can have. So we have to use our knowledge as our power, and use that knowledge to be able to help us make good descriptions and be able to help us provide the information that we need to be able to avoid adverse events. There was a really good paper that came out recently in a high impact journal. So this is Nature Scientific Reports. So this is a very high impact factor journal, and it looks at a retrospective analysis of the incidence of severe adverse events among recipients of chiropractic spinal manipulative therapy. And it was a neat study because they looked at almost 1 million adjustments. So they looked at 960,140 adjustments. It's a shame they couldn't have got 40,000 more, because it would have been nice to just round it up to 1 million. But anyway, they looked at 900,000 adjustments, and they looked at adverse events, and they considered them based on severity. So 1 being a mild adverse event, 2 being a moderate adverse event, 3 being a severe adverse event, 4 being life-threatening, and 5 being an adverse event that resulted in death. And of those nearly 1 million adjustments, there were only 39 adverse events identified. And only 2 of those adverse events were at grade 3. And so that grade 3 event, both of those were considered a severe adverse event. And what they were rib fractures. And they were rib fractures that occurred in women who were over the age of 60, who had osteoporosis. So that combination of features led to that possible adverse event in that population. There were no adverse events that were rated grade 4 or higher. So there were no life-threatening adverse events, and there were no adverse events that ended in death from nearly 1 million adjustments. And so that tells us that that it's a fairly low occurrence of adverse events when it comes to spinal manipulation. So reassuringly, it's a fairly rare thing to have a bad event happen. But often what will happen in conversation is people will ask about neck manipulation and stroke risk. And a study came out a few years ago that looked at this specifically. And they found that vertebral basilar artery stroke, which is the type of stroke that people have thought is associated with going to see a chiropractor, is a very rare event. And in Ontario, they looked at over 100 million person years of data, and they came across 818 cases where there were vertebral basilar artery strokes. And for people who were less than 45 years of age, they found that those people were more likely to seek healthcare for their issue. So they would seek healthcare because they had a headache. They would seek healthcare because they had neck pain. But there was no evidence suggesting that it was chiropractic that caused that particular effect, and that these people were equally as likely to see their primary care physician prior to having this stroke occur. So if they saw their primary care doctor or they saw a chiropractor, they ran the same risk of developing this particular type of stroke. So it's not a cause and effect situation. It was most likely they had some pain, they sought care for it, and that pain was reflecting this stroke in progress. And there is the article for that. But you may say to yourself, after hearing the evidence that I've presented today, this Passmore guy, I don't know, he's full of baloney. He's saying all these things and it doesn't jive with what I see. I'm in practice every day and I see a lot of other conditions that are responding to chiropractic care. My patients are telling me that this is what is actually happening. What can we do about that? Well, if we can't say something is true based on the evidence, we have to think about what is our experience. And so if you're experiencing something in clinical practice, it doesn't mean that you haven't had patients tell you that they've noticed something. It doesn't mean that you haven't made observations in your own practice about what you're seeing and what's responding to care. But one thing that's important to note is that these observations, while interesting, are technically anecdotal and they're not based on data. So they're not considered evidence-based. And so it does mean that if you want to explore those kinds of questions and concepts, that more high quality research is needed to generate data to further our understanding of what works and what doesn't work. And when we look up an anecdote is really just a short story or an interesting event or occurrence that we've been able to observe. And when it comes to anecdotal evidence, it really just means that it's not supported by data. It is simply that story. So without data, you can't really defend your observation. So if you're trying to defend your observation or communicate it to the media or to patients or to other healthcare practitioners, you need data. So what does the future look like when it comes to research and these kinds of ideas? Well, a really interesting article came out a few years ago that talked about the trend toward moving to clinical registries and evidence-based care pathways, and using those to try to look at data on a much bigger scale. So it's one thing to be a scientist in a lab like me and building these little bricks of knowledge all on your own. It's a much different thing to be a part of a clinical registry or an evidence-based care pathway where you are looking at multiple clinicians reporting to this common data site. And they can record data on every single patient that moves through a particular clinic. So for spine surgery in Canada, there's a network called CSORN. And the CSORN is the Canadian Spine Orthopedics Research Network, where every patient that gets spine surgery has a base level of outcome measures and demographic information that's collected and then run through and looked at. Here in Winnipeg, we've actually created a database for our publicly funded clinic. So we have a publicly funded clinic called the Mount Carmel Clinic, and we use our database to capture data on every single patient that moves through that clinic. And we use that data for quality assurance to be able to report back to government and other stakeholders about what's happening in that environment. Who's being seen? How many times are they being seen? What are they being seen for? What kinds of outcomes are they having as a result of that care intervention? So by having these kinds of data sets and registries, we can make very big generalizations and very big statements about what we're seeing in practice on the front line of care. So the future is now, and there are researchers in our profession that are working on trying to explore these evidence-based care pathways. And at the Health Sciences Center, which is the largest emergency department here in Winnipeg, we are actually doing that. We are starting a study to look at how many people are moving through that facility, how are they being treated, and we're creating that registry locally to be able to say what we can and can't do and what we're seeing and not seeing based on the front lines of clinical practice. I'm also involved in a research project that's happening on Cross Lake First Nation or in Pimichigamac, and we're looking at using the Global Spine Care Initiative and World Spine Care models as evidence-based care pathways for this particular community that currently has no access to spine care, but through our research study, we'll have access to spine care and is excited to collaborate in looking at what spine care can do for their community. So can you imagine, there's 139 participants on this call right now. Can you imagine if every person on this call pooled the data of every patient that walked through the door of their clinical practice? We would be able to learn so much about who is responding to care, how quickly are they responding to care, what kinds of techniques are they responding to, who's not responding to care. how quickly we could figure out all of that kind of information. Are there adverse events that we're seeing associated with the kind of care that we're delivering? And if we had that massive database, then researchers like myself could delve into that and try to explore what we're learning from you folks on the front lines of clinical practice. So that brings us back to research, and we need to support and conduct research on the questions that we identify as important to our profession and as clinically important to our patients. And Chiropractic in Canada entrusts the CCRF to help us to know that our donations are being put to good use. And the CCRF has also helped build research capacity in our profession by creating a network of research chairs across our country. And these chairs can then supervise new DCs interested in pursuing master's or PhD degrees, and allowing us to continue to build our potential for research in Canada. So it's through research that we can find the truth of the day, and what is working and what is not, what we're doing well, and potentially where we need to change. Through research evidence, we can communicate what we know to be true to our patients, our colleagues, and other healthcare professions. We can communicate the truth to the government and other stakeholders like insurance companies and worker compensation boards who have a real interest in the type of work that we do. When we see the evidence that we have, we can make a point of acting on that evidence. Or we can recognize in a specific area, maybe we need to update our evidence or do new research. Always remembering that we need to do our best to stay current, but we need to stay flexible in our views so that as new evidence emerges, the challenges, what we've thought before, we can really appropriately scrutinize it and learn from it in order to determine its value in how we can help our patients who are turning to us to knowledge and are seeking our care. So thank you all for your time and attention and consideration. I really appreciate the opportunity to speak with you today.
Thank you, Dr. Passmore. I found that to be a fantastic presentation, and the flow and kind of the overview of research and the impact of research, and then really I think the impact of the quality of research on what we can and can't do in practice, or not what we can and can't do, but what is evidence-based in practice. As we've gone through, this time we have now is for questions, and we have some questions that have been received. I'm going to kind of prioritize questions that really kind of meet up with your presentation and kind of go from there. There's lots of questions that are being asked, which is fantastic. Some of the questions are, I think, more applicable to what you present, and some may have to be answered afterwards if we don't have time. So we'll go from there. And the first question that I'm going to bring it up is does relying heavily, and I'm just going to read it, if not exclusively on published evidence, discount and disqualify other forms of care that have not had sufficient funding or support to further investigate these interventions? So and even though clinically they prove to be very effective, kind of a long question, but with it, I think what they're asking is like, what about other research? And you kind of spoke to it in your thing, but do you have any in your presentation, but do you have any further you could say about it?
I do. And, anecdotally is what we see in clinical practice. So if you're in clinical practice, you're seeing things, it's an anecdote, and that's an interesting place to start. And that's a really great place for you to identify a good question that can be brought forward to do research on. So you can say to a researcher, hey, I've noticed this in clinical practice. Is there any research on it? And if there is, maybe that researcher can help you find it. And if there isn't, well, then maybe you can design a high quality study to really test that. And so you can test that observation that you've had anecdotally, and then be able to say, oh, okay, at the end of that study, yeah, there is evidence that can be published now because of this research study and process that we went through to try to understand what is happening in that particular clinical situation. And then if other labs also start to replicate that kind of work, then you can have a larger body of evidence that emerges. And then in the future, years down the road, a clinical practice guideline may be developed that explores that. And so research is always evolving, and these clinical anecdotes is the starting point for those.
Perfect. And that's good. Next question that I think, and this may be kind of the same line and stuff out there, but one of the questions is when the evidence relies heavily on, maybe there's some bias even in the question, but on biased sources and evidence about discounting, disqualifying, or otherwise ignoring information that agrees with the author's biases, how can we trust the information that is out there? I will have to stop at that. That's a lot. And to ask it once, and then there's a second part to it that we can follow up with.
Okay. Yeah. So when we're looking at evidence and we're looking at what gets out there, it is ultimately what is published. So to get published, you have to go through peer review. And it's a long process, and you have to be patient with these kinds of things. You have to design a study very carefully. You have to follow appropriate rigor. But then when you submit it to a journal, it should not be biased in terms of a peer reviewer is intended to look at it with an open mind and to evaluate the quality of the science that was conducted. Was the appropriate rigor involved in the methods? And if so, then great, the outcomes are what they are if the statistics were all done correctly and that sort of thing. So when it comes to the evidence generation process, that's really what it's meant to be. And the peer review process should be very, very open-minded in that sense. So as long as the methodology is solid, the outcomes are what they are, and the scientific community can then judge it once it's become published. And so there are a lot of different journals that are out there that have different impact factors, and they have some of them are very profession specific. So we have the Journal of the Canadian Chiropractic Association, but then we have other ones that are very vague and vast within a specific area. So there are journals like Spine or the European Spine Journal, which just involves anything that pertains to the spine. And then you have even broader scientific journals that look at any research question that you might have. So a journal like PLOS One or Nature or Science or those types of things will look at, the breadth of research that exists out there, not just things that are spine specific. So research can be published in a lot of different places, and so it's sort of unfair to say, well, this is really biased for a particular journal, because there are a lot of different options on where to publish.
That's perfect. And follow up to that, listening to you, and I think that's something that you're probably very familiar with because it's the world you live in. But when you talk about the peer review process, like you've obviously been a peer reviewer, and you've also had your work peer reviewed. Maybe you could just highlight the rigor that goes into that, so that there's some perspective for us to consider as clinicians.
Yeah, sure. So as a scientist, I will do a study, I'll write it up with my students, and we'll come up with something that we think is great. Where we say, okay, this is a great article, we need to share this with the scientific community, so we'll present it at a conference, and then we'll look for a journal where we can share this information. And so we find that journal, and then we submit it, and we think, okay, now it's out there for peer review. What's going to happen next? And the editor for the journal will make a very quick decision. So they will either look at it and say, oh, this isn't a good fit for our journal, and they'll send it back, or it will be identified as something that is a priority for the journal, and then peer reviewers will be assigned. So the journal editor will identify people who have expertise in the area that you are publishing in, who are anywhere in the world. So these could be people in Australia, in Europe, in South America, who have an interest and an expertise in where you're trying to publish. And so then they will carefully read through your article, and they will make a decision that says, yes, we feel that your science is valid. We want to help you publish the best version of your article that we can. So here's some suggestions to make for a revision. Or they'll look at it and they'll say, you know what, your question is fundamentally flawed, and your methods are flawed, and here's how and here's why. And that is a context where you learn in both of those situations. You either learn how to make your next study better, or you learn from the peer reviewers who are trying to help shape your article to be the best version that it can be, to be shared with the broader scientific community.
That's fantastic. It is a rigorous process. It's not just let's get this out there for somebody else. One of the questions, and I think this comes from your talking about the database at Mount Carmel, and I think because when I read the question, we'll just go to answering. I'm just going to close the other question there that was asked. This one says, would this clinical registry require a unified documentation process? I see it being challenging to translate different clinical vernacular to extract the full value of a registry like this.
Yes, so it's not easy to start a registry. If it was, we would have one and it would be perfect and everyone would use it. But we don't have that, and people do things in very different ways. And so there are people around the world that are exploring ways to try to do this? Do you create some sort of a standardized electronic medical record where all of this information can automatically be extracted as soon as someone signs up or signs into this? That would be a beautiful way to do it, because then it minimizes any extra burden on the practicing clinician. You can just take the notes the way that you do, and the information that you mentioned will be pulled out and put into a database that can be looked at by a scientist. But there are other ways that you can create a registry as well, by having a separate file from your normal electronic medical record or paper-based file, where you are just writing down specific things and putting them into a separate document that then can be shared. But it does have to be standardized. And if it's standardized, then you can make sure that you're collecting the same data at all the different sites, and then you can really speak to the pooled data as an entity. And so it's not an easy task to do, but there are countries that are making real headway on it. One of them is Switzerland. And so in Switzerland, they have a registry that about 50% of the chiropractors practicing in Switzerland are actively engaged in, and they're just generating a ton of research knowledge from that. And I would love to see the same type of thing happen in Canada. If we were able to create that uniform way of collecting data and being able to share it, it would really, I think, benefit our patients.
It'd be interesting to see if the will and effort to sustain that develops, and I think it's a compelling case for it, because it does build that knowledge database for the profession. One of the questions I think that's tangential to that is, in your registry, is it purely looking at MSK, or do you consider other factors like baseline health measurements like blood pressure and different things like this? I know there's a question in here specifically about that, but in regards to that, like, what kind of stuff goes into the Mount Carmel registry? Right.
So at Mount Carmel, it largely is demographic information. So looking at who is being seen and like their age and their apparent sex and gender and those sorts of things are all being recorded. And then also looking at things that are highly relevant to the chiropractic course of care. So the number of treatment visits, the types of techniques that are being utilized. But we do also consider comorbid diagnoses. So if they have, other pathologies or things like that, that gets recorded as well. And we look at their active medications. So what medications are they currently on? What are they using recreationally? And we collect that data as well, so that we can say, oh, okay, it's possible that whatever treatment outcome they're having is being positively or negatively influenced by these other factors that could be happening in this patient's bigger picture.
Yeah, that's fair. It is exciting. So one of the questions that I'm going to ask, and some of that's my answer, some of that I think you'll actually provide a better perspective. So this question is, why is the 2008 study by Bacris, published by the Journal of Hypertension, not supported by the CCOA or other Canadian institutions, even though it's considered to be the gold standard RCT? And I think part of that comes to, that was included in the study. You alluded to the study, but it was the one that you were referring to around dysmenorrhea, but they looked at primary or non-MSK conditions, and that study was considered in there. And I think that your analysis or meta-analysis came to the conclusion there wasn't, not yours, but that meta-analysis came to the conclusion there wasn't enough evidence at the time to support that chiropractic is effective. One study may have had results, but in the meta-analysis, the data still doesn't support that as an intervention. And you probably be able to speak further to that. I don't know if you're familiar with the exact study itself, but are you able to make comment on that?
Sure. I was involved in the process that generated the article that came out that looked at the non-musculoskeletal issues. And so they had a whole team of 50 or so experts from all over the world come together and rigorously go through these different studies. And so all of the working groups looked at the quality of the different studies that were conducted. And even if a study seems to be conducted relatively well, sometimes there are very specific holes in studies that do exist. And if those holes exist, then it causes us to lose confidence in those findings. And so when it comes to evaluating a randomized control trial, we use very specific guidelines and rubrics to be able to identify all of the different facets that should be there in terms of appropriate blinding, appropriate outcome measure testing, all of those different factors that go into generating a high quality study. And unfortunately, in this situation, based on the rubrics that were used, that study was deemed to not be of sufficient quality to stand alone as evidence for why chiropractors should provide that kind of intervention. So it just is what it is in terms of the quality of the evidence and how it was scrutinized. If there is a positive effect there, then it should be replicable in a future study. So if someone does do another future study with a 2023 perspective on quality of study and design, then we'll be able to have a better understanding of, does chiropractic affect hypertension, and does it do so in a way that can be replicated by other laboratories around the world. And if it does, and we see several labs coming to the same conclusion, then a future clinical practice guideline will say, hey, this is a good thing. But until that happens, we can't say that there is evidence for it.
Perfect. Thank you. That was a very detailed answer. One of the questions that came in, and I think it's probably a topic of the day, is why do you think the role of AI, or what do you think the role of AI will play in the future of chiropractic research?
Well, I can tell you that I'm actually writing a grant right now where we're looking at using AI to generate some stimuli that will be used to look at how chiropractors determine a dosage of chiropractic care to deliver. And so, we're all in our practices every day, and we see people come in that are all different shapes and sizes. And how do we know that we're giving those people the same dose or the appropriate dose for them to be able to respond to care? And so I recently published a paper that looked at this question specifically with visual stimuli. So we presented life-sized avatars of humans that had different BMIs. And so we looked to see, was there a difference in how a clinician thrusts based on the size and shape of the individual present? And our plan for the future is to use AI to have even more realistic avatars that we present as we're continuing to explore this question of what is a dose of spinal manipulation, what is a dose of chiropractic care, and how do we define that so we can understand what dose response is and understand what we can do for different populations.
Perfect. We did receive a follow-up question to your response to back rows and all, and I think you did answer it, but if there's further clarity you can provide, that would be good. It says, if there are holes in studies such as the back row studies, how did it pass peer review in 2008 for the Journal of Hypertension? And then, but then it said, and then I think they say biases seem to affect peer review, example, Corso and all from 2020. And so I think what they're asking is like, well, if it was valid in 2020 and met peer review, what changed when that review was done in 2020?
Right. So it really, I'm not familiar with the Corso 2020 study, but I will speak to the 2008. So in 2008, the world was a different place. I mean, that was quite a number of years ago. And so what happens is scientific processes evolve and scientific scrutiny really evolves. And the amount of research that comes out every year increases exponentially. So we have a tremendous knowledge base that continues to grow. And so that particular study may have been in 2008 acceptable to the peer reviewers of the Journal of Hypertension. It doesn't mean that same article would get published today. So if you sent it to the 2023 editorial board of the Journal of Hypertension, they may say, okay, based on your methodology, here are the flaws in it, and we're not able to publish it at this time. And so research that is more than 5 years old when it comes to clinical trials is sometimes considered to be in a dangerous position of being able to be interpreted with a lot of confidence. And so clinical practice guidelines are recommended to be updated every 5 or 10 years or so that it can stay abreast of the most current evidence that we have. And evidence is always evolving. So what is true today is true today. And in 10 years from now, maybe we'll be talking about lots of different things that there's evidence for, but today we only have the evidence that we have. And if there's not evidence for something, then that's a catalyst to do more research and to try to explore other questions.
I appreciate that. I think there's going to be some questions that we don't have time to get to today. And maybe what we can do is, they seem to all be from the same presenter. Please reach out, contact me directly. I'll see if we can answer those directly for you, and if not, I can see if coordinate an answer with Dr. Passmore. But in in parting, Dr. Passmore, I really appreciate the time, the presentation you provided today. I think it was, I think the quality and the delineation of one, the impact of evidence and where do we find good evidence for clinical practice has been really important. But, you know, if you had to provide any kind of last messaging, key messaging, things you really want us to take home and understand when we go to practice tomorrow, what would you say?
Have confidence. There's a lot of really good clinical practice guideline research that's out there that supports things that we're very good at that the rest of the medical community struggles with. So when it comes to neck pain, back pain, headaches, those are things where we have excellent clinical practice guidelines, really good evidence that supports what we do, and it helps us to fill that void for people that are coming to see a primary care doctor. The primary care doctor may be frustrated and not know what to do with that particular patient. And by saying, you know, here are our high quality clinical practice guidelines, here is what we know we're very effective and good at. You know, it could be a source of referral for you, or it could be a source of confidence in just having conversations with patients or other healthcare providers. So use the clinical practice guidelines that we have. And, you know, if you also are looking for another thing for your clinical practice, come up with ideas, you know, think about things and reflect on them and think, okay, we need research on this particular topic or in this particular area. And then, you know, approach researchers or even, you know, decide to do a master's or PhD yourself so that you can drive that next generation of knowledge forward.
Yeah. Well, and just prior to the presentation, I appreciate the comment. Dr. Passmore was talking about a student he just finished supervising that returned to do his master's and PhD after 30 years of clinical practice. Apparently curiosity got to him enough that he took action on it. So, you know, I'm still kind of tickled pink and celebrating the success of a colleague who took that step in action to go back and develop the skills to do the research. We really appreciate the time that you've taken. I know that I don't know if sometimes we look, you have such ease with the material, but it takes hours of preparation to coordinate and get prepared to speak about a topic like this, even though you're already an expert in it. And so I really appreciate the time that you've taken. This recording will be available for members. I'm going to turn some time back over to Dana at the end of the presentation, just for the last few kind of housekeeping items, and then we'll move on from there. Thank you so much, Dr. Passmore. Much appreciated. Excellent quality information today.
Thank you. It's been my pleasure.
Awesome. Yes, thank you. I concur on those sentiments. And we also appreciate our attendees and your questions. Expect a post-event survey in your inbox coming soon. We look forward to receiving your feedback. Lastly, this webinar will be archived for future viewing on our website. Have a great afternoon, everyone.